Now we start our debate on the same topic. I'm glad to invite Dr. Saed Ali. He will be with the motion for surgery in treatment of symptomatic carotid artery disease.
Good evening, and thank you for this kind invitation. I think this is a very important result because we're talking about reality, what we do actually in reality. In reality, surgery will establish since 1950. It's grown like a baby, follow up all the time for the last 70 years. We know everything about surgery. We know the indications, many study. Okay. So all the studies showed that surgery is more superior. And the people, and the group, they prefer stenting. Actually, they go with the flow of technology. Surgery here to stay. Simply, as great Professor Norman Brown said, surgery to take the disease away, stent to palliate the disease. In the opposite side, if we compare this with the aortic surgery, endovascular will replace the open surgery. But stent for carotid is not going to last. But let us verify the question again. What we are debating about. We have facts in hand. The fact is, surgery is superior in all aspects when compared with stenting as a primary therapy for symptomatic carotid artery disease. We know for sure when the surgery can be difficult or impossible or carry major risk in a hostile neck or very high lesion. So indeed, the risk of stenting, it will be reasonable and accepted. All the study, randomized controlled study, when compare the stent with surgery as a primary therapy, showed at least raise of the stroke associated, non-fatal stroke associated with the therapy, at least 2 to 3-fold extra. And while the stroke rate improved in every institution all over the world, we accept far less than 0.1% associated with surgery. The stent still carry a higher risk. So stent, actually, when we look at the study of the stent, why the stent is inferior and why the people work on the stent, they try to find somehow to satisfy or identify high risk group. Why? Because simply surgery happened by only one person, vascular surgeon, controlled by or cooperated by a neurology, but stent done by radiologist, neuroradiologist, cardiologist, done for reason and for no reason, and done for reason accepted and no reason accepted. And who going to take the follow-up and the risk of management if the stent fail? Is the radiologist or cardiologist? We have to be very honest and very real about this. Surgery in the carotid artery is here to stay. Why? Because it's a delicate artery. We have to ensure the anastomosis, the cover, the closure, all well monitored. All our patients discuss in the MDT meeting, and we know everything. Neurology, the anesthetist, it has to be a neuro anesthetist. The follow-up, the 4 hour in the recovery rate, recovery area, everything well controlled. But let us go back to the stent. What we have in the stent. We have no control on the device, in the personnel, in the follow-up. We don't have any person to even to litigate, to look at what can we do for them. And remember, if you leave a stent in a carotid and you ask a vascular surgeon to come, actually you invite him to more difficult cases. But if you come to all the study, I'm not going to recruit, all the study in the carotid stent showed at least 2.5 to 3 I'm talking about primary indication for stent. So if the debate about primary disease, I can say surgery here to stay. And all this done for surgery. The block morphology done for surgery. What you going to do if you're going with wiring through this? And the block, the occlusiveness of the disease, unstable disease. And also, you have to know more than the area you need to operate on. When you have to operate from the groin, you have to know much about the aorta. What about the aortic arch? What you fail if you canalization? So you need to do all this for area you're not going to operate on. All this you need to know about it. And you're working in certain area. You can do it under general, under local, shunting, non-shunting, batching, non-batching, and you are responsible for patient. We know if the patient does not recover in 4 hours, we know when you intervene, what you do. But what about stent? Stent, we have nothing. Nothing about the stent for primary disease. So, surgery here to stay. Surgery here to stay. Remember, we are not led by technology. We're leading technology because we're talking about natural course of a disease, responsibility toward the patient and the patient outcome. And remember, stroke is a major disability. Might change the patient's life and subsequently the society. Thank you.
Thank you very much, Dr. Said.